This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today, we're looking at a fascinating new study from Acta Neurochirurgica, published in early 2026. It's a systematic review titled Spontaneous Regression of Associated Aneurysms After Management of Arteriovenous Malformation.
This is a topic that comes up constantly in our vascular boards, and more importantly, in our multidisciplinary team meetings. We see an AVM, we see an associated aneurysm, and the question is always, which one do we treat first? And if we treat the AVM, will that aneurysm just go away?
Exactly. It's that classic hemodynamic puzzle. The authors, Gutierrez and colleagues, really dived into the literature to see if we can actually count on that regression. But before we get into their results, let's set the stage with the pathophysiology the paper describes. We know an AVM is a tangle of dysplastic vessels, the nidus, that shunts blood directly from the arterial to the venous system without a capillary bed.
Right, and that high-flow, low-resistance conduit is the culprit here. Chronic high flow produces dilation of the feeding arteries. The paper notes that this high-flow vasculopathy is the primary explanation for why these aneurysms form in the first place. Increased blood flow through the arterial feeders contributes to vessel wall stress.
And the prevalence is higher than some might think. The study mentions that while AVMs themselves are found in about 1 in every 2,000 MRI scans, the rate of associated aneurysms ranges from 2.7% all the way up to 52% in the literature.
That's a huge range. Now, for the residents listening, Alara, how did the paper classify these aneurysms? It's a distinction that matters for the study's inclusion criteria.
The authors use the standard 2 categories. First, we have flow-related aneurysms, or FRAs, which make up 85% of these cases. These are located on the arteries supplying the AVM. They can be proximal, like on the circle of Willis, or distal. They even mention intranidal aneurysms, which represent about 5.5% of those flow-related ones.
And the second category?
Those are the non-flow-related aneurysms, or NFRAs. They make up the remaining 15% and are located on remote vessels that have no relationship with the AVM. Interestingly, this systematic review focused specifically on the flow-related ones, because the theory is that if you remove the shunt, the FRAs should regress due to decreased intravascular pressure and vessel remodeling.
That's the dream, right? You resect the AVM or embolize it, the pressure drops, the wall stress decreases, and the aneurysm vanishes. But medicine is rarely that simple. Tell us about the study's methodology.
It was a rigorous systematic review of PubMed, Embase, and Scopus as of May 2025. They looked for studies involving patients over 18 with intracranial AVMs and associated FRAs. They excluded small studies with fewer than 10 patients and those involving only conservative management. They ended up with 10 studies meeting the criteria, totaling 428 patients.
And these were mostly retrospective cohorts?
Yes, mostly retrospective, with a moderate risk of bias according to the Robbins eye tool. The patient demographics were fairly standard for AVM studies, average ages between 31 and 58. Crucially, over 50% of patients presented with a hemorrhage.
That brings up a major point of controversy mentioned in the paper, the timing of treatment. If a patient comes in with an intraventricular hemorrhage, which one do you hit first?
The paper is quite clear on the general consensus. The priority is the lesion responsible for the hemorrhage. If it's the aneurysm, you treat that first because of the high risk of re-rupture. But if the source is undetermined, or if the aneurysm is unruptured, that's where the regression strategy comes into play. The idea is that treating the AVM first allows for that spontaneous regression.
So what did the data actually show? Did these aneurysms disappear as often as we hope?
Well, the numbers were a bit of a reality check. The observed regression rates across the studies ranged from a low of 3% to a high of 23%. When they pooled the data, the rate of spontaneous aneurysm regression was only about 11%.
11%. That's lower than I think many of us quote in the clinic.
Much lower. And the authors noted that because of possible publication bias suggested by their funnel plots, the true rate might be even lower than 11%.
That's a significant finding. Did they find any specific factors that predicted which aneurysms would regress? Did AVM size or the completeness of the AVM treatment matter?
This was one of the most interesting parts of the results. They found no consistent correlation between the rate of complete AVM obliteration and the rate of aneurysm regression. They also didn't find a solid link to the aneurysm's specific location or type. Most of the AVMs in these studies were Spetzler-Martin grades 1 to 3 and were supratentorial, but that didn't seem to guarantee regression either.
That's frustrating for clinical planning. If we can't predict it based on AVM obliteration, it makes the wait-and-see approach a bit of a gamble. What about the mechanism of regression? The paper mentions the drop in flow, but did they suggest other factors?
They did. Beyond just the hemodynamic shift, they noted that things like hypotension, severe vasospasm, the use of antifibrinolytics, or even local damage to the artery wall during treatment could potentially lead to an aneurysm regressing or thrombosing.
So it might not just be remodeling. It might be a combination of several physiological insults to the aneurysm.
Exactly. And because the pooled rate is only 11%, the authors conclude that spontaneous regression should be considered exceptional rather than expected. They really emphasize the need for vigilant follow-up. You can't just treat the AVM and assume the aneurysm is gone.
This has real-world implications for how we consent patients. If I have a patient with a Spetzler-Martin grade 2 AVM and a 4 mm distal FRA, I can't tell them there's a 50-50 chance it disappears. Based on this review, it's closer to 1 in 10.
Precisely. And the paper notes that the highest observed probability in any of the included studies was still only 23%. It reinforces that management must be individualized. We have to weigh the risks of direct aneurysm treatment, whether endovascular or surgical, against this relatively low probability of spontaneous resolution.
Did the review touch on the different AVM treatment modalities? Like, did radiosurgery have different regression rates compared to embolization or microsurgery?
The studies included patients who underwent surgical, endovascular, and radiosurgical management, but the review suggests that the phenomenon of regression is recognized but variable across the board. The central theme remains the reduction of flow through the feeder, regardless of how you achieve it. However, the lack of a consistent correlation between AVM obliteration and regression suggests that the hemodynamic relationship is more complex than just turning off the tap.
It's a reminder that these are dysplastic vessels, as the paper calls them. The biology of the vessel wall might be just as important as the pressure inside it. If the wall is already structurally compromised, a drop in pressure might not be enough to trigger remodeling back to a normal state.
That's a great point. The vessel remodeling mentioned in the paper requires a certain degree of plasticity that might not be present in every patient.
So, to wrap up the key takeaways for our listeners, spontaneous regression of flow-related aneurysms after AVM treatment is a real phenomenon, but it's rare. The pooled rate is 11%, it doesn't seem to correlate strongly with how well the AVM was obliterated, and it requires strict follow-up imaging.
Exactly. The author's final word is that further studies are needed to guide treatment strategies. But for now, we should treat each case with a high degree of caution and not rely on regression as a primary management plan.
Well, that's a sobering but necessary update for our vascular practice. Thank you, Alara, for breaking down this systematic review.
My pleasure. It's definitely going to change how I look at those post-op angiograms.
And thank you all for tuning in to the Neurosurgery Hub podcast. We'll see you next episode.
Goodbye, everyone.